Podcast. We are sorry that there is a delay in the start. We apologize. Just we had a technical glitch. We got it solved now. So today is March 18th, 2025, and we are continuing with our dermatopathology lecture series. And we are happy to welcome back Dr. Jacqueline Junkins Hopkins today. This is her second lecture, and she is a dermatologist and a dermatopathologist at Geisinger Medical Center in Pennsylvania. And today she is going to talk on connective tissue and metabolic disorders. Thank you so much, Dr. Hopkins, for joining us today. Over to you now.
Thank you. It's great to be here. Hi, everybody. I can't see you, but I'm assuming you're there, I'm paying attention, eating your lunch at the same time. I'm going to talk about sort of, in general, deposition disorders and some connective tissue or collagenous or dermal problems. This is where I practice at Geisinger Medical Center, which is in rural Pennsylvania, not too far from a few big cities, but still rural. So here are some different things we're going to talk about. Mucinoses, the hyaline deposits or the eosinophilic deposits like amyloid and its sort of mimics, some metabolic deposition disorders, some exogenous deposition disorders. And then in the end, I'm going to try to hit collagen and a few elastic tissue disorders. I don't know. I'm sure most of you guys have seen some skin, but we'll take you back to medical school or early residency to show you what the histology looks like for normal skin. You have the vascular stratum corneum, normal epidermis, and this little tiny area underneath the epidermis with these more wispier, fine collagen bundles is a papillary dermis, and this can get expanded or fibrotic and sclerotic, and different things can happen here. And then the thicker collagen bundles are the reticular dermis, and within this are vessels and nerves and things. And then in between there are the glycosaminoglycans or GAGs, and in the dermis these mucinous depositions are high hyaluronic acid. So it's sort of part of it, but it can be increased sometimes. So here's normal reticular dermis. You can see the collagen fibers are running in different directions. And you can see these sort of crisp outlines of the collagen bundles with some spaces in between. And with disease, sometimes these can become swollen and you can lose the spaces. This just shows sort of a neurovascular unit within this with some space around it, and sometimes the space can get lost as the collagen bundles swell and compress in conditions such as morphia. So I figured I'd start with the deposition disorders, in particular the mucinoses, which are sort of pretty common in our daily practice of deposition issues. So the mucin basically is removed in processing, and then what's left is this stringy, grainy material that's bluish in between the collagen bundles, or as a pool of mucin within the dermis. In the dermis, it's the hyaluronic acid or the non-sulfated acid mucins. Sometimes you can have chondroitin and dermatan sulfates. This is in contrast to the mucin that can be seen in the GI tract and in the other glandular lining, epithelial linings. So mucin can be seen, as I mentioned, it's part of the collagenous dermal structure, and so you can see it normally in around the vessels, around the adnexal structure, sometimes in the papillary dermis, and sometimes as the dermis is trying to repair itself, you can sort of see it as the scar tissue is being laid down. And we can usually see it under H&E as this grayish, bluish, stringy, granular stuff. But the stains we can use to highlight it even better include colloidal iron, Alcian blue at a pH of 2.5 as opposed to a lower pH, and toluidine blue, which is more of a sort of a purplish color. I personally like to use the colloidal iron. I'll show you examples of that later. So sometimes within the mucin deposition, you can see these larger stellate fibroblasts. Some people refer to them as mucoblasts. They usually aren't too prominent. If you get it to be very, very cellular, you have to think of things like scleromyxedema, which I'll get into later. So this is an example of Alcian blue staining the blue connective tissue, or so the blue mucin between the connective tissue bundles. So just going to talk about some of the primary mucinoses that are in the dermis. So this includes mucinosis associated with thyroid function dysfunction, a group of lichen myxodermatoses or papulomucinosis, which includes generalized and sclerodermoid or scleromyxedema, localized variants. Just to back up on the thyroid dysfunction, the thyroid dermopathy is a pretibial myxedema, which we usually get biopsies of. But people who have general hypothyroidism can have mucin deposition in their skin that's a little milder, and that clinically presents as sort of puffy, firm, sort of dry skin, sort of a puffy face. But I'm not going to talk about this today, but I just want to mention it. Other conditions included in the primary mucinoses include scleredema, reticular erythematous mucinosis, or REM, nodular mucinosis of connective tissue disease, in particular lupus, cutaneous focal mucinosis or focal dermal mucinosis, digital myxoid cyst, which is really a pseudocyst. It's also called a mucus, but most people call it digital myxoid pseudocyst, mucocele of the lip. I'm not going to talk too much about self-healing juvenile cutaneous mucinosis. And then there are some other variants. Sometimes if you have obesity and stasis, you can get the lymphatic changes and edema there. And sometimes after radiation, you can get mucin. Then we can also see mucin in, of course, Granuloma annulare. The collagen is being altered and sort of degenerating, and you can have mucinous changes there. You can have mucin in the hair follicles of cutaneous lymphoid hyperplasia or just follicular mucinosis alone. Dermatomyositis and lupus can have background mucin deposition without having the nodular cutaneous lesions. And sometimes with Dego's disease, it can actually simulate dermatomyositis with epidermal atrophy and diffuse dermal mucin. So starting with thyroid dermopathy or pretibial myxedema. So here these patients have Graves' disease, but they won't always have hyperthyroidism. Sometimes the Graves' disease can have been treated, and at that point they might be euthyroid, but they can still present with this. They get these depositions within the dermis of the usually anterior legs, but you can also see it on the feet, as you can see here. Sometimes it can present as a nodule or a tumor. Sometimes it just stretches the dermis without affecting the hair follicles and can give a peau d'orange change. It's usually later after the disease, but it can be the presenting sign. And it comes with a triad, supposedly, of findings. You get exophthalmos, so your eyes are protruded out, and so you have lid lag. I can't really show you because my my video's off, but when you sort of have your patient follow the finger, the lid, because the eyes are protruding out, the lid lags, and you can get a space between the eyeball and the lid, so you get the white of your eye showing. And then you can get thyroid acropathy, which is sort of like a clubbing. You get periosteal new bone formation on the fingers. So here's an example of pretibial myxedema. It's this this is from the old scanner, which is not as nice as the newer ones, but you can see usually a little granuloma sparing. You can see this light blue coloration, and the collagen bundles are splayed. I have a better example. Here's a higher power showing collagen bundled splayed by this grainy mucin deposition. Here's another one showing, again, the granuloma sparing and diffuse replacement of a lot of the collagen by these pools of mucin that splay the collagen. Again, the granuloma sparing is sort of common here. This is another example, again, granuloma sparing and diffuse deposition of mucin splaying the collagen bundles apart. And if you would stain this, it would be all blue in between with colloidal iron or Austrian blue. Moving on to lichen myxodermatosis or papulomucinosis, there are two main forms. This usually presents in adults. I don't know that I've seen it in kids. So there's a localized version where you have these waxy papules that are often coalescent plaques. It might have some linearity to it. These patients have no systemic conditions, in contrast to the scleromyxedema, which I'll get to in a second. It always corrects to popular. So acral persistent papular mucinosis is a localized variant. You can also have this in infants, and then there's a nodular version of this. And so the scleromyxedema has a very classic presentation. A lot of times on the forehead and glabella is where you can see it most prominently. You get these waxy papules that sometimes can have some linearity to it. And this is arising on a background of some dermal sclerosis. And this is important to recognize because these patients will have a monoclonal gammopathy, usually IgG lambda. You have to exclude thyroid disease because, as I mentioned, you can have thyroid deposition, mucin deposition and thyroid disease. And then you see a specific collection of histopathologic findings, which I'll show you in a second. The other important thing to note with these patients is they have neuropsychiatric dysfunction. I remember years ago, a patient sort of couldn't balance their checkbook anymore. And then that was one of the initial presenting signs. And, they eventually started to lose their capacity, and it corrected when they had treatment of this. And you can get some, joint symptoms when you have compression with sclerosis around certain nerve areas. And then there's some intermediate or overlapping forms. So here's your typical presentation. Again, one of the older images or an older scanning processes, but you can see it's not just dermal mucin. The dermis is very busy. It almost looks like it could be a dermatofibroma or some other spindle cell process. And then there's mucin in between. So the triad is the mucin deposition, which is in between, plus the prominent fibroblast proliferation, and with that is an associated increased number of increased collagen. So you can see the myxoid change in between the collagen bundles, in addition to increased fibroblasts. So nephrogenic systemic fibrosis, initially, when these first came out, people thought that they were an odd presentation of scleromyxedema because you have the same increased bland fibroblasts in the dermis with mucin deposition within it. This was found eventually to be due to gadolinium exposure, especially with people with end-stage renal disease, and can be diagnosed by the presence of CD34 staining of these fibroblasts, which is different than leukomyxedematosis. And these patients also present very distinctly with acrally accentuated sclerosis of the fingers, the hands, the legs. I had a few slides that I borrowed from one of our residents, and this is one of them showing these sclerotic bodies that can be present within lesions of nephrogenic systemic fibrosis. And again, the mucin can show up. So this, fortunately, we don't see as much because we're now aware of the condition. So acropersistent papular mucinosis, you have sort of the scleromyxedematous changes, but these more sort of solitary appearing papules, usually on the dorsal acral sites like hands, wrists, forearms. And these patients, even they don't have the diffuse sclerosis, they don't have gammopathy, and it tends to be well circumscribed, more just mucin, not so much in the way of fibroblasts. So it's still grouped in the same category, but it is a little different histopathologically. And here is from my friend Franco Rongioletti, who has really devoted his life to studying the mucinoses and publishing on them. So he's done a lot of work on this, but so I borrowed this from him. And you can see here, increased dermal mucin, not as many fibroblasts. It's sort of more of a true mucinosis there. Another slide from him. This is rare. It has the acronym of ASOP, but the ASOP doesn't really have the mucin in it. But you basically have a localized area of mucin angiomatosis, and this can overlie a plasmacytoma. So these patients can have regional adenopathy. They have this violaceous plaque, usually on the trunk, chest, or maybe sometimes back. And so this can be associated with Pohm syndrome and Castleman's disease. But if you have a plaque, somebody says, rule out, morphia or something like that, you've got a lot of mucin, consider this diagnosis. And you get mucin deposition and increased vessels, not a lot of inflammatory change here. So moving on to scleredema, also called scleredema of adultorum of Buschke. Here patients initially present on the back of the neck, upper back, with firm skin changes. It can be often sort of erythematous. Maybe if they have darker skin, it can be more sort of just darker discoloration. And this can present in patients who have had longstanding diabetes mellitus. It can present in patients with HIV, tends to be associated with the paraproteinemia, and it's also present in kids and adolescents. And in that situation, they have rapid onset, usually after an infection like a URI or a strep infection. Um, and they have this striking sort of firmness of their skin. It really can be very restricting. They sometimes will have it be expressionless as it hits their face. They'll have trouble moving their neck. It can really be quite debilitating. And here, this is a patient of mine that I had, and here's a close-up showing that, so just sort of increased dermis with maybe some mucin causing some pot orange change here. This is his biopsy. I took one of the thick area, and I tried to get one of a sort of non-involved area, although sometimes you can have involvement extending beyond that. And what happens, you just have more collagen presented. So, I tried to get as deep as I could, and I still couldn't get to fat here. And what happens is usually the eccrine coils are at the base of the epidermis, and then you start getting into the fat. But here, basically, you have so much collagen deposition all the way down, and it makes these eccrine coils just sort of land in the center. And so you can just see the main problem is just way too much dermis. So there's just a normal example of where the eccrine coils usually lie. And it's different in different areas of the body, obviously, but you can see, the striking amount of dermis that's present. This is from picture a long time ago. I don't have the source. I apologize. I have some pictures in here where I don't have the source. But here's sort of normal dermis, and here's just a striking amount of extra collagen. And so it's put in the mucinosis category. I think what happens is you just have more collagen being laid down. And because high hyaluronic acid is part of the whole process, you get extra mucin. So I imagine if you took a biopsy of an older lesion, you wouldn't have as much high hyaluronic acid identified in the dermis. So here, staining with colloid iron. I like this because you got sort of the regular pink of the collagen, and you got the blue sort of streaking through. It looks really pretty, I think. Here's just another example. People talk about fenestrated collagen. You see here, this is also from our teaching set. You can see splaying of the collagen a little bit by this grainy, bubbly mucin on H&E. Reticular erythematous mucinosis. I don't usually make this diagnosis because it's hard. You need the clin path correlation. And a lot of people think it's the same as tumid lupus. You have small, bland lymphocytes around the vessels, sometimes around the adnexal structures, and gobs of mucin deposition or high hyaluronic acid. And this is usually sort of central chest with a plaque that looks a little reticulated, and that's why it has this name. But again, some people, it's maybe controversial, but some people think it might be the same as tumid lupus. Here's just a close-up view of that. This is distinct. So this I took from the literature. The papulonodular cutaneous mucinosis associated with lupus erythematosus. They get all these dermal papules due to the presence of mucin deposition. You can see it also with dermatomyositis and sometimes with scleroderma. But I think this is sort of very striking. Usually patients have systemic lupus with the joint and renal involvement, etc. I don't have a picture of this one, but patients who are obese and have the really large legs eventually get the almost the elephantiasis nostra type bumps on the legs. Can also, if you take a biopsy, show a lot of mucin deposition there. This is just for fun. This is a kid who had these bumps on his scapula, and he had mucin in the dermis, maybe subtle fibroblasts in between, not a whole lot. And this is the Hunter's mucopolysaccharidosis that can rarely be seen. It's a storage deficiency, but I wasn't going to focus a lot on that. I just put that in for fun because I thought it looked nice. Digital mucus cyst, or it's really a pseudocyst, as I mentioned. You have sort of the mucin that is extruding supposedly from the joint capsule, usually at the distal finger, but you can really have it sort of anywhere along the finger, where there's a joint. We usually see it at the distal finger, and it can, the nail bed starts way back here. So if it's arising here, where the matrix is, you're going to have an abnormally formed nail. So you'll have a trough or nail dystrophy here where you have this presenting. And sometimes it's flesh colored, sometimes it gets a little warty because it's, maybe being rubbed and traumatized and getting some LSC and stuff on it. So it can present in different ways. But histologically, basically, you get a big pool of mucin. It's a pseudocyst. It's not a real cyst because it sort of compresses the collagen as it gets spewed into the collagen. You have this big pool, and it acts as a space-occupying lesion. You can see it compresses the overlying epidermis. Sometimes this can be a little ulcerated and crusted. And again, the same mucin. You don't really need colloidal iron. Sometimes I'll just get a little shave and I'll get some crust, and sometimes I'll just get a colloidal iron to show that there's mucin in the crust there. But clinically, you sort of know what it is, and they help us out with it. So here's one where the mucin sort of mostly fell out. You can imagine getting this, and maybe they popped it and some fell out. It also shows how it's really just a pseudocyst. So mucocele is a rupture of the minor salivary gland duct, and you have spewing of mucin here, and it sort of goes away, and then you have this granulation tissue-like reaction and granulomatous reaction around it. So pseudocyst as a reaction really to the mucin that's been extruded. Focal dermal mucinosis or cutaneous focal mucinosis is a solitary papule, usually sort of head, neck, upper trunk, sometimes the extremities, looks like a dermal nevus or roll-up BCC or something like that. And just like everything else, you get a pool of mucin sort of interdigitating between the collagen bundles at the edge. And so it's just a solitary localized thing. You don't usually have to work them up for any conditions like thyroid. Granuloma annulare, I think those of us who do dermpath are very familiar with this. You have an interstitial deposition or infiltration of histiocytes. Then you start having altered collagen. It's referred to as necrobiosis, which really we shouldn't say. It's like live dead, but you have probably some degeneration of collagen. Maybe it's starting to make more collagen, but you have mucin here in this area of acellularity, and this is surrounded by histiocytes, sometimes multinucleated giant cells. So this palisading around this mucinous collagen degeneration is your classic granuloma annulare. You don't really need to get mucin stains for this. Sometimes you'll just have a little bit of interstitial stuff at the periphery without the palisading of the mucinous degeneration, like down here. And sometimes it can be helpful to do this to show that it's interstitial granuloma annulare as opposed to interstitial granulomatous dermatitis that might be due to a drug where you have the interstitial cells. Necrobiosis lipoidica diabeticorum is sort of a cousin of granuloma annulare, where you have, instead of a circle of the collagen deposition, you have these horizontal layering. People refer to it as layered cake. The same idea here, though. All right, amyloidosis. So I'm trying to give a little bit of clinical on all these things, but I can't go into super depth on this. But so amyloidosis, you can have systemic and primary cutaneous. So with systemic, you have the amyloid deposited in all sorts of organs, in tongue, in your skin, around the vessels, in your heart, in your kidneys. Your tongue starts to increase in size, and as it pushes against your teeth, you can get these ridges at the edge of the tongue. It can just be very large, like some of the macroglossia the tongue can almost be a little bit obstructive almost. You have a deposit around the vessels and in the connective tissue of the dermis. So the dermis itself is not that structurally intact, and so you have easy bleeding, especially if you've had proctoscopy or colonoscopy or vomiting, where you have valsalva pressure around your eye. Pinch purpura, again, the vasculature is not well supported because it's got amyloid instead of collagen around it. So these are some of the clinical presentations that these patients can have. And they also have, my other picture is gone. They can also have waxy papules, especially around their eyes. And this is usually due to monoclonal immunoglobulin light chain, usually lambda, and so this is referred to as amyloid AL. And you can also have primary, then there's also secondary amyloidosis due to an infection, chronic infection, maybe like TB or something. And that's derived from alpha globulin. It's referred to as serum amyloid A. So primary cutaneous is often due to the keratinocytes being a little damaged, and then they spew out their cytokeratins, and then can cause some amyloid deposition or alteration in the papillary dermis. There's a macular and lichenoid variant, and I'll show you examples of these. Usually they're pretty itchy. Then you can have nodular localized cutaneous amyloidosis, so I'll show you examples of those. So the nodular type can be on the trunk, can be on the extremities. I've seen it on the extremities that eventually will result into some wrinkling or atrophy. They are sort of a reddish brown, yellowish color. Again, depends on the skin color. In a dark skin patient, it might just be more of a brown, hyperpigmented coloration. And this is indistinguishable from systemic amyloid. So you should probably still work them up if you get a nodular amyloid diagnosis. So basically, you have this hyaline pink material deposited into the dermis. And at low power, it might be hard to really tell the difference between that and the collagen. But if you look closely, it has these sort of solid, smooth, homogenized eosinophilic areas with cracks in it. So these cracks are very characteristic, and sometimes the cracks get lined by fibroblasts. So here you have the pink deposition, smooth in areas, cracked in other areas. You can see here, I try to outline sort of where it ended, and the collagen bundles themselves are nice and crisp outlines. You don't have that smooth eosinophilic change, even though the color is very similar. Just higher power, so you can have increased fibroblasts in here sometimes. A lot of times you're going to have hemorrhage because, as I mentioned, the vessels are a little not as well supported, so hemorrhaging is common. Here's another example showing this smooth, homogenized eosinophilic material compared to the surrounding collagen. Another example showing the cracks you can see within the amyloid. I try to find this pseudovascular change. I try to see if there's anything in the literature. I found this from 1953, some proceedings talked about it. But it can be almost looking like a lymphangioma, but this is really probably lined by fibroblasts. Again, the hemorrhage is common. It's not uncommon to see plasma cells, especially with the nodular primary cutaneous. You often will have plasma cells. Sometimes they can actually show monotypic staining. Just another example, smooth deposition compared to the surrounding collagen bundles, hemorrhage, cracks. And then this is in the fat showing perivascular amyloid deposition with plasma cells, a common presentation. So we don't always need the stains, but we like to get the stains, although a lot of times they don't work so well. Some people refuse to get Congo red, but I do think it works if you have real amyloid. It's usually sort of a salmon color. This looks a little bit more red than usual. You can use crystal violet also will stain it. PAS will also stain it, sort of the pinkish color. Here we use thioflavin T, but you need to go into the immunoscope room. This is the case that I showed you earlier of the shave biopsy with the amyloidosis. So you can see this bright coloration here. And amyloid will have on polaroscopy will be have this apple green birefringence. Other dyes, this is always on the test, I guess, but I've never used this pagoda red, and none of these I've used. I guess if you really had to, you could do EM, and it shows non-branching filaments of a certain diameter. You could use some of the cytokeratin immunohistochemistry to show it in the primary cutaneous lichenoid and macular amyloidosis. Here's just an example of perivascular amyloid deposition in the subcutaneous fat. Here's Congo red. I don't know if you can tell that it's sort of that salmon color here. So this does work. Here's it compared to sort of the surrounding connective tissue. Here's crystal violet, again, highlighting it. You can sort of see it anyway on H&E, but it's nice to prove it. And then the apple green birefringence that you can see. So again, here are the stains that I showed you, Congo red on that same case. You can see this is different than the surrounding collagen a little bit, maybe. Here's a thioflavin T. You can also use trichrome, which will show the collagen is blue, and it's not really staining this the way collagen should stain. Here's just the example here of that case with the trichrome around the outside showing that it's not collagen. Sometimes I'll get pink stuff in the dermis and I'll just get a trichrome to see what it is. Like sometimes I can't tell, is it plasma, is it amyloid, not sure what it is. And this sometimes will help. So for systemic amyloid, a lot of times we're asked to do a blind fat pad biopsy, and I know derms don't like to be the technician, but I think it's definitely worth doing. You can see in somebody who has amyloidosis, in the studies vary, but you can see it in up to 95% of some cases. I don't know any derms that do rectal biopsies. If so, then I might have to report you there. You can also do foreign, but I think most people do fat pad biopsies. And so, oh my God, we don't have that much time left. So lichen amyloidosis, usually on the anterior legs, very itchy. It can be seen in anyone, but it's seen a lot of patients of Asian descent. Macular amyloid, more of the rippled hyperpigmentation, but there's a lot of overlap with these. Here you can also see it in Middle Eastern as well as the Asian and South American and Central American communities. So these are from the literature. You can be hyper or hypopigmented. These are extreme examples of the lichen amyloidosis. And here macular, a lot of times when people have notalgia paresthetica, they can have macular amyloidosis affecting the scapular area just from chronic rubbing. And lichen amyloidosis, low power can look like maybe LSC or seborrheic keratosis. You can get some hyperkeratosis. You get widening of the dermal papillae with deposition of the amyloid material. Macular amyloid is really going to be the same idea, but a little bit less hyperkeratotic, less hyperplastic for the epidermis, and usually a little bit less of the material. Here's another example showing this smooth eosinophilic material with cracks. A lot of times you see post-inflammatory pigment. You see, again, widening of the dermal papillae, sometimes a claw-like reedy around that. Here's an example where these colloid bodies, due to an interface reaction, are showing some, I don't have the stain with me, but some amyloid change. And these are examples of cases in which if you stayed it with CK903 or some other keratin marker, these would light up. Sometimes you can see amyloid within other neoplasms, especially basal cell carcinoma. I've seen it associated with Bowen's disease also. Bowen, no S's anymore. Colloid milium, I don't like to talk about it because I've almost never seen it. To focus on the adult colloid milium, you usually see it in areas of chronic sun damage, on the dorsal hand, sometimes the ears, maybe related to trauma. And similar to amyloid, similar to colloid bodies, you see deposition of the pink material with fissures and cracks in it. Here's another higher power of this, very similar to amyloid, a lot of the fibroblasts here. Here's another example that has these smooth deposits of colloid milium with these fissures. So this is a very classic presentation. We have this pink stuff, very distinct from the surrounding solar elastosis with the fissures and cracks. Here's just another one here. Porphyria, we're all familiar with that. You get fragility of the dorsal hands due to chronic, sometimes chronic blistering. You get alteration of the collagen. These patients have abnormal porphyrin metabolism, and their hands have frequent blisters. A lot of times you won't even see the blisters. You'll just see scabs. Or I had one patient tell me his hands were like gelatin. He just barely touches it and they rip. So porphyria cutaneous tartar is one we see most. You can get the same presentation with variegate porphyria. They might have attacks of intestinal pain with this. You can also see this in patients with Hep C. And histologically, you see this pink hyalinization around the vessels, which is PAS positive. You can see here also around the basement membrane zone, PAS positive, around the vessels, this sort of ribbon-like material that you can also see on direct immunofluorescence. You can, if you don't have a blister, you can just take an area of the skin itself that tends to be, involved by the disease. If they don't have an intact blister, a lot of times you can get DIF findings just of that if you biopsy the area that has been involved. This has extension into the surrounding collagen. You get this eosinophilic sclerotic type material. This causes the firm dermal papillae to festoon into the blister cavity, which we all learn about in the blistering disease studies. Lipoproteinosis is a very rare autosomal recessive disorder in which patients get this deposits in their skin, the sclerotic deposits, and they have this very characteristic beading. You can sort of see it here, but you can also see it here, beading of the eyelids. They get these pock-like acneiform type scars, these waxy papules and plaques. They can have neuropsych disorders, seizures. As a baby, because of the vocal cord involvement, they can have a hoarse cry. So here, this is PAS to sort of highlight it. You get this amorphic eosinophilic material in usually the epidermis here. You get sort of onion skinning around the vessels. And you can see here and around the deep eccrine coils, this onion skinning type of PAS positive sclerosis. And this is what helps differentiate this from porphyria, because porphyria can also have PAS positive material around the vessels and in the dermal papillae, but the deep involvement will help you differentiate it from lipoid proteinosis. Gout, due to hyperuricemia, they get deposition of the urate crystals, usually around the joints, but it starts to spew into the skin. You can get it with flares. You can also have it in between flares, and with time, you can just have it sort of chronically deposited in the peri-joint areas. The ears, elbows, toes, fingers are common places. And these are urate crystals. Pseudo-gout is due to calcium pyrophosphate dehydrate crystals, which are a little different. So gout, again, low power, you have amorphous eosinophilic, usually a little more pale staining, sort of lavender staining material. In the derma is often surrounded by a granulomatous infiltrate. And if you look closely, the crystals dissolve out, but it leaves these wispy changes here that look very feathery. So here you have surrounding sclerosis or fibrosis, some multinucleate giant cells, and then these areas of sort of pale staining material with this feathery appearance. Sometimes you have to move your condenser down to show it a little bit more with surrounding histoacidic response. If you stain it, if you fix it with alcohol or Conroy's solution, you'll see these brown crystals. So the crystals should stay in here. Here they've dissolved out. Here's another example of probably almost like a touch prep type thing where they used alcohol to fix it. So calcinosis cutis, a lot of different causes. Idiopathic, dystrophic is the one we see a lot where there's been chronic inflammatory condition or some specific situations like infants who've had a lot of heel sticks, they can get calcinosis of the heel. A lot of causes of metastatic or hypercalcemic related calcium deposition. Here, a list of some of the things that you should think about, especially. Sarcoid is one that I think a lot of people forget about. If people are eating a lot of antacids, they can get it from, milk alkali syndrome. And then there are systemic conditions, especially juvenile dermatomyositis can have it, and CREST. So you see this really deep vasophilic material deposit. I think a lot of us sort of can easily recognize this. It could be in vessel walls, it can be just massive deposits, tumoral calcinosis, and then you can see fibrosis and multinucleated giant cells around the edge. Here, dystrophic calcification due to sort of chronic fibrosing material or process with calcium deposition. Sometimes it will be granular. If you just imagine some of these, sometimes it'll be hard to decide if it's calcium or bacteria. So you can do a von Casa stain to help decide that. Here, massive calcification pushing up against the epidermis. The epidermis is sort of surrounding it with a collarette. This is subepidermal calcified nodule. You usually see it on the head and neck area, especially in kids and young people. Here you have, again, calcinosis cutis with surrounding fibrosis. It's almost sort of annular. If you look here, you can see where we have darto smooth muscles. So this is calcinosis, idiopathic calcinosis of the scrotum, which is probably due to an infundibular cyst that has popped and had secondary calcification. So look closely for the smooth muscle bundle, and sometimes if you look closely, you'll see a little face that will just smile at you in some of these situations. Sometimes you can get calcification within adnexal tumors. Here's a basal cell. It can be helpful, as you can see here, in making a diagnosis of desmoplastic trichoepithelioma. Oh, sorry, this is wrong. Trichoepithelioma, not trichomoma. Pilomatricoma, you have a circumscribed area of calcification, and you have the ghost outline and the matrical cells. You can get elastic tissue calcification in pseudoxanthoma elasticum, where you have these squiggly deposits of calcium on these altered elastic tissue. Calciphylaxis is an end-stage, seen in end-stage renal disease, although sometimes you can see it in non-uremic cases. A lot of these patients have protein C and S deficiency, so they get clotting. And these tender, sometimes initially cellulitis-like, but eventually necrotic areas, usually on sort of areas with more adipose tissue like thigh, buttock, calf area. And what you have is calcium deposition within the subcutaneous tissue. If there's been compromise, you can see necrosis of the epidermis too. And you can see it's involving the small vessels as well as some of the medium-sized vessels. And you can stain this with von Casa. Here you can see the purple calcification with von Casa. It's black. You can see it really highlighting the amount of calcium really all over the subcutaneous fat. As I mentioned, you can have a lot of death and necrosis due to ischemic or sometimes clotting problems. And here there's increased cellularity within the dermis. I didn't have the stain to show you, but you can have diffuse dermal angiomatosis as a dermal sign of calciphylaxis. So if you stain these are all SMA positive, and it's sort of a immature vessel formation as a consequence to slow ischemia. You get medium vessel involvement, but this is not diagnostic of calciphylaxis. It probably reflects the fact that the patients have arteriovascular disease. It's also referred to as Munkenberg's medial calcific sclerosis. Just examples of the calcification you can see in the vessels. A lot of times you have thrombosis within these areas. Here you have early thrombosis plus calcification. Just another example of thrombosis. So this is a common thing. It could almost, you can have inflammatory cells come in. It could almost look like a primary leukocytoclastic vasculitis. You can in addition to calcium, you can have true bone formation associated often with dystrophy and chronic scar-like change. You can also have osteoma cutis in acneiform scars. You can have I don't have an example here, but on the forehead, you can get a button osteoma where you have a disc-like, well-circumscribed area of bone formation. Not going to say too much about cartilaginous disease, but here you have a piece of cartilage, and if you look closely, you've got neutrophils at the edge, sort of breaking into the cartilaginous tissue, and this is an example of relapsing polychondritis, which we know now, if you see this, you have, especially in an older man, you have to consider VEXAS syndrome, because this is one of the presentations of VEXAS syndromes. Pigment deposits, tattoo is, going to be the color of the tattoo clinically. We see it with traumatic tattoo, like from a pencil lead, or you can see it from a tattoo from an artist putting the images on the skin, and it's black, often associated with multinucleate giant cell reaction. It's helpful to recognize the tattoo pigment because sometimes you can have other conditions that are induced by tattoo. So here we have sort of a wedge-shaped process with atypical cells that are CD30 positive, sort of looking like lymphomatoid papulosis, but you can recognize the sort of reddish color of the pigment-laden macrophages. So this is TAT2 reaction mimicking LYP. You can have a pseudo sarcomatous reaction. It looks like KA or squamous cell carcinoma. This is a case that we published a while ago with a reaction to red TAT2. And if you look closely, you can see the TAT2 pigment here. Hemochromatosis, you have iron deposition in the skin associated with systemic conditions that include diabetes, cirrhosis, arthritis, especially of your first two, your index finger and your second finger. And then you have deposits of pigment that is positive for pearl expression blue, indicating iron in the skin. Ochronosis. So wait, David, are you on or is Rafat on?
Here too.
Do I need to stop at one or should I don't know how long this is. I have a
No, it's okay.
I think it's
you can
okay.
continue.
Yeah.
Sure.
Usually
right.
lets you go over, so it's fine.
All right, because well, just tell me when you want me to stop. I don't know how many slides I have left. I did most of it already, but I'll just try to go a little faster because people have to go and go to do all the stuff that they have to do at 1 o'clock. So I know people aren't just hanging out, just listening to lectures. So I'll try to hurry. So ochronosis, you can have systemic ochronosis that's due to endogenous ochronosis. It's an autosomal recessive disorder. And they have a lack of homogentic acid oxidase. And so they have accumulation of homogentic acid in the cartilage, ligaments, tendons. And they present early on with a black diaper sometimes because the urine turns black. It's referred to as alkaptonuria. They also have arthritis, especially on their back. They lose their lumbar lordosis. They have black pigment around their eyes and on the cartilaginous areas. So that's rare, but a very distinct clinical presentation. And then you can have exogenous induced ochronosis due to local inhibition of HGA oxidase. And I'll give you an example of that. It's seen in patients who use hydroquinone, although a lot of people use hydroquinone and it's not a common cause, but it is something you need to watch out for. Again, this is taken from, I think I gave a talk on this when I was maybe a medical student or resident. So these, I don't even know where these came from. I apologize. But so you can see here, he's lost his lumbar lordosis. He can't really bend over here. He's sort of locked in. He's got these deposits here on his back. And you can see all this black material here in endogenous ochronosis. The cutaneous findings, as I mentioned, you can get the ulcer sign, we get the black deposits on the sclera. You get deposits on all sorts of calcified areas, but it's going to show up where the skin is thinner, like the nose, the ears, things like that. Again, an old picture, maybe it came from archives years ago, but you can see this woman who'd been using hydroquinone has these almost caviar-like papules on the cheek. Now when we see it, it's going to be a little bit milder because we're aware of this condition. And you can see the this came from not this person. This is a case that I'd had years ago. But you can see this ochre color or this yellowish color of deposits in the dermis. And here's another example. And what happens is you get deposits and alteration of the collagen bundles. So these are sort of in the shape of these altered collagen bundles in the dermis. It's very distinct. Sometimes it can look a little bit like blue nevus. Of course, this is the really crazy version of it. Almost looks like an art of somebody who I can't, but it looks like art sort of, doesn't it? Anyway, and so blue nevus though can sometimes have some overlap if you have it early, like here. But you can see with blue nevus, it's associated with dendritic melanocytes. So you can see the nuclei involved in these areas. But you can imagine here looking like maybe early ochronosis. Here's just another area with less prominent deposition. And this is what it looks like if you do it on fresh tissue. That's a case from a really long time ago. So another thing in the differential of this is localized argyria with pseudo-ochronosis. So here you get deposit of argyria from silver implantation. A lot of times it's in jewelry makers or people, who've poked their skin with silver. And then you get the silver deposits onto the collagen fibers and elastic fibers. So here you can see it nicely highlighting the elastic fibers in the papillary dermis. It's also regular argyria is going to be present around the blood vessels and eccrine coils, and this will do the same thing here with the fine granules. And you can see how it starts to look a little bit like ochronosis here, but it's called pseudo-ochronosis. Oxalosis, you get accumulation of oxide crystals in the tissue. You can have it as a hereditary or primary disorder where you have some clotting problems, and you can have it acquired, like people who drink ethylene glycol and some antibiotics can do it. I didn't know rhubarb leaves could do it, but that was on the list. People who have renal insufficiency can have problems eliminating it, so you're going to see it probably in that class of patients. And you get these almost sort of rosette-like collections of these rectangular sort of grayish beige material surrounded by multinucleated giant cells, so very distinct. Another cause of deposition, you can see here, normal, normal, normal. Then the epidermis is effaced, and then there's some subepidermal fibroplasia. And if you look here, you've got material that's sort of a grungy purplish. Again, these are the prior scanning system, so I apologize, they're not great. But it's sort of a grungy purplish material within the histiocytes, and this is due to aluminum chloride or Drysol when people have tried to stop the bleeding. So this is a paper I did with Sylvia Gottesman, who does a lot of online stuff, one of my former fellows, and you can see this grungy purplish granular material within the histiocytes, and these stain positive for PAS. I've actually, sometimes you can't find the surgical site. And there have been some cases in which you can barely find it. And if I look for these, can be very, very helpful to say that, yes, they excise the right spot. So this is different than the Muncell's reaction, which is a 2 pigment from the Muncell's medium that's used to stop the bleeding. And it's going to be iron positive. Gel foam is another deposition situation that you can see in surgical sites. People who do punch biopsies and don't close them can stop the bleeding by putting gel foam in. And you see this really sort of bizarre maze-like angulated purplish material that is the gel foam. Here's just another example, the closer view. All right, so we finished the deposition type things, although I added a little bit at the end of fillers, but we'll just move on to the collagenous conditions. So scleroderma is sort of the main one. You have systemic or localized. I'm going to spend more time on the localized sclerodermatous processes. You can also have eosinophilic fasciitis, which has some overlap, but has a very sort of classic presentation clinically where they have sort of acute onset induration of the limbs. You get the groove sign on your inner arm, and these patients can have peripheral eosinophilia. They can have some serology that looks like connective tissue disease. They can have a lot of different systemic associations. And a long time ago, this is the one that was associated with L-tryptophan. So scleroderma, basically the nice discrete collagen bundles that I showed you earlier are all just merged into this sort of diffuse sclerotic material, sclerotic change of the dermis. You can sometimes see the collagen bundle still here, but they're very sclerotic. You can see the papillary dermis is homogenized and sclerotic, not really homogenized, but very smooth and sclerotic. You lose the periacrine fat. I showed you earlier that you had sort of loose connective tissue around the vessels. You can lose that around those too. So these are clues to scleroderma. And these patients, I'm not going to go into the whole clinical for them, but they have, diffuse involvement of their skin with a lot of restrictive dermopathy, and they can have GI motility problems and a whole host of other problems. Localized morphia clinically presents as sort of hypopigmented areas, a lot of times hyper around it. People refer to it as a lilac ring. Sort of breast is an area you can get it, buttock, inner thighs. And then there's a variant that you get on the scalp called Kutasab, or like a laser cut or saber cut. and it's usually a little bit indented where you've got the morphia changes going into the fat, and you have a little bit of a collapse of the fat of the dermis surface due to the morphia involving, the full thickness of the dermis and fat. So it's scleroderma, but sometimes it actually doesn't feel that hard, but it is, firm, but it's not sort of locked in like the systemic sclerosis. Um, and sometimes you can have the surface looking like LSNA histologically and clinically. So the biopsies, you've got the collagen being replaced by sclerotic collagen, and so you have a very sort of squared off biopsy. You also have, as it goes into the fat, it goes with a pushing border. So you have what's been referred to as a line sign. Here, this is from Max Fung and colleagues article. A lot of times you're going to see plasma cells. Sometimes you'll get a biopsy from the back and it might look a little like morphia. If you saw periacrine fat, that helps to sort of show that it's just back tissue. Here's just another example with line sign here and plasma cells. Here's a high power showing sort of you lose a nice crisp edge between the collagen bundles. They're all swollen and sclerotic, and you can see it replacing the fat here. Although here it's probably spared. So up here, you're going to have your normal collagen bundles. And so you can see the difference between the top part and the middle part. So the involved part, you lose all the discrete collagen edges. Here's an example with the inflammatory stage of morphia with a lot of plasma cells. A lot of people like to check spirochetes for things like this. Again, inflammatory presentation. Sometimes, as I mentioned, it's hard to decide if it's like back. It's sort of one of these invisible biopsies or other situations where you're trying to decide if it's morphia or not. You can get CD34, and there should be an absence of staining in regular collagen, whereas it's going to be positive in these dendritic cells between the collagen bundles in normal dermis. Sometimes it can involve the fat. You can see morphia profundus, where it's really the subcutaneous tissue that's involved. And this basically is a similar presentation as eosinophilic fasciitis. But with eosinophilic fasciitis, you're going to classically have a lot of eosinophils, although they might be hard to find. Like in sclerosis, you have the collagen. Wow, these pictures do not look good at all. I apologize. You have epidermal atrophy with hyperkeratosis, interface change, and this widening. It almost looks like edema of the papillary dermis with lymphocytes beneath it. The same sort of thing on the penis. So a lot of these are going to occur on the vulva, perianal area of women, but on the guys, they can get it on the penis. Again, combination of hyperkeratosis, interface change, widening of the papillary dermis with this smooth, homogenized collagen. You can have dermolytic blisters, and then you have inflammatory change beneath that. Radiation dermatitis can also cause sclerosis of the collagen, also with an interface change. You're also going to get vascular dilation, which you can see in lichen sclerosis as well. But here you're going to see these bizarre radiation fibroblasts that are hyperchromatic and larger. Hypertrophic scar, nodular fibrosis, usually in the background of regular scar. So scar, you usually have parallel orientation of collagen with epidermal effacement and increased small vessels. Early on, they're going to be up and down. And then with hypertrophic scar, it becomes more nodular. You get this sort of hyperplastic myofibroblastic proliferation here. Here again, you're going to have regular scar here, and then you get these big balls of the myofibroblastic proliferation with the collagen. Again, you can see here with these bland cells, and the interspersed small vessels is also part of this. If you can't tell if it's a scar, you can always do a Verhoef and Giesen elastic stain showing absence of elastic tissue in the scar and presence of normal elastic fibers in the dermis. With time, you can start to get a little bit more elastic tissue in here, but they might be a little bit more fragmented. A keloid is usually associated with areas of hypertrophic scar, but in addition, you get these eosinophilic bundles that people refer to as bubblegum collagen. Sometimes you can have almost all hypertrophic scar and just a little bit of the bubblegum popping up. It's still keloid if you're starting to get that, but here's just sort of an exuberant example of that. And here's a hypertrophic scar area. You can see areas of microcystic fat change or lipoatrophy. And this is where they've injected steroids to try to get the keloid down. And you can see how steroids have affected the fat there. Here's another example with steroid deposition of the triamcinolone, usually this bubbly lavender color, with also associated with lipoatrophy. Chondrodermatitis nodularis helicis is also sort of considered in this group of disorders. It's got a combination of acanthosis that's benign. Beneath this, there is vascular proliferation. And in the center, the epidermis is usually a little bit less hyperplastic. And you get altered collagen. A lot of times you get fibrinoid necrosis. And if they go deep enough, you can get a little bit of an altered cartilaginous tissue. Here's another example. These are taken from the ASDP slide library. Acanthosis, telangiectasias beneath this, central area where it's a little flatter, and then this very pink, smooth fibrinoid necrosis is classic feature here. You may or may not have ulceration. Everyone looks for ulceration and cartilage, but a lot of times you won't see ulcer, and you won't always see that. So look for the acanthosis, vessels, and fibrinoid necrosis. And a lot of times you can see sort of elongated pycnotic keratinocytes in the overlying epidermis. Scleroderma is alteration of the connective tissue, which we're all aware of. It becomes, in the face, head and neck, it's smooth, solid, light purple material, distinct from the surrounding collagen. But in other areas of the body, you might just see some of these collagen bundles, these elastic fibers alone, not as a solitary presentation as face. Pseudoxanthoma elasticum is a condition in which you have this deposits in the skin of calcified abnormal elastic tissue. They can also have involvement of the eyes and Bruch's membrane. They can have GI involvement, cardiovascular involvement, where you have the vessels being abnormally, you have abnormal structures that can cause problems. But in the skin, we see it sort of in the intertriginous sites. And you see altered elastic fibers are all sort of crunched up. They can get sort of purplish color, even more purple if we do special stains. But here's an example of the calcification of the abnormal elastic fibers that have been referred to as bramblebush. Don't know why. I guess it sort of looks like that. Sometimes it can perforate. So here you have hyperplastic reactive squamous epithelium with material in it. As you can see, it's perforating. Here's the abnormal PXC fibers, and you can see they've sort of entered and they're on their way out, surrounded by this reactive squamous hyperplasia. Here you have the elastic fibers starting to perforate out, and this one is, this is elastosis perforans or pigmenosa, where you have abnormal collagen elastic fibers similar to perforating PXC, but these are not as abnormal histologically, but they just start to perforate through the epithelium, and you can see them collecting in here as vertically oriented, altered fibers. Here's another example of perforation of material here, and you can see staining with a Verhoff-Van Giesen stain. It stains black, and you can tell that it's elastic fibers based on that. Almost done. Reactive perforating collagenoses. This is due to trauma or scratching usually. It's similar to some of the other perforating disorders, but it's not going through the hair follicle. But scratching will cause elimination of altered elastic fibers through a neutrophilic crust. And then lastly, I just want to talk briefly about fillers. There are a lot of different fillers that are used, and I think if you guys are residents listening to this, you're going to have to know about most of these here: hyaluronic acid, polylactic acid, calcium hydroxyapatite, and silicone. And they have very classic presentations. So hyaluronic acid or mucin is going to be the same color of mucin, but it's very smooth, and you can see just pools of it because they squirt it in your skin and just sort of stays there, and usually causes a sort of collagenous reaction around it. But sometimes you can have multinucleated giant cells in a granulomatous reaction. And so this could be an incidental finding, or it can be something that is being specifically removed because of granulomatous reaction. And you can see it staining for ashen blue here. Calcium hydroxyapatite are these sort of beigeish light purple spheres surrounded by granulomatous inflammation. Here's another example, these sort of beigeish tan. Sometimes it can look a little purple, but these very round, distinct material surrounded by multinucleated giant cells. Polyallactic acid is going to look like little rice grains or tiny little spindle-shaped spicules, surrounded by multinucleated giant cells. Here's another example here, almost like a keratin granuloma. And then silicone granuloma, you're going to get the Swiss cheese, so different shapes and sizes of the vacuoles. This is not the same as adipose tissue, and it's usually going to be in the dermis. You can see it staining with CD68 to show that they're histiocytes. Here's just another example of silicone granulomatous reaction, different shapes and sizes of the vacuoles. And that is all. Should I stop sharing? What do I do?
Yeah, thank you so much, Dr. Junkins, Hopkins, for this excellent talk on connective tissue disorders. Yeah, you can turn your video on. And we also have with us Dr. David Casarino, one of our speakers in the dermatopathology lecture series. And
Hey,
he is actually
Hello.
helping.
how you doing?
Good. How are you?
Good.
So Dr. Casarino, would you like to add something?
No, I think it was a great talk. Thank you very much, Jacqueline, for covering that. Very interesting and complicated topic, and I think you summarized it really well.
Thanks.
I don't know if we have
There's
any
so much
questions.
more I could talk about, but never enough time.
Yeah, time's always a limiting factor. If there's any
Yeah.
questions, we can try to address
Yeah,
those.
there
Right?
are a few questions I saw online. One question is that I think you mentioned about it, but still that if you would like to highlight the spectrum of early versus late stage cutaneous involvement in systemic sclerosis and how this may affect the diagnosis.
So for systemic sclerosis, to be honest, I have not personally seen biopsies that I've been able to confirm were early. So usually by the time it's confirmed, it's a little bit more, it's usually more developed. So I probably can't answer that from a specific experience point of view. I don't know, David, have you had biopsies of early scleroderma?
Yeah, I think it just looks a lot like early morphea, though. So you can't really tell between early, primary cutaneous limited scleroderma versus systemic scleroderma. I think, whether they're early or late, they basically show the same features. So, it's really based on the clinical findings,
Yeah, that's what I was going to say.
Serology, stuff like that.
Right. One of the signs I learned early on is to, pull up the skin on the dorsal hand, because that's usually very pliable. And in systemic sclerosis, it gets locked down. And then the other thing from, again, clinically, losing the pads, the digital distal pads goes early on, at least back from my medicine days. But
the dermatologist may be able to separate it, but I think for pathologists, I think it's very hard to separate them.
Yeah, I don't think you can.
Yeah.
And I also don't think you can separate, and as you alluded to, systemic scleroderma from localized morphea.
Right. I always put a disclaimer in, even when I favor morphea, that they should rule out systemic scleroderma clinically.
Yeah. Oh, I don't do that because they're so distinct clinically in terms of,
But sometimes we don't get the history. If we don't get any history, you don't know.
Yeah.
All you're getting is biopsy of a lesion or a rash, and it may look like classic morphea, but if they're not giving you any clinical history, you don't know any of the serologies, maybe coming from an outside institution where you don't have access to their clinical history and other information. I think it's good, at least for a pathologist, to put in that, or dermatopathologist.
No, I think that's smart. Yeah, I agree. I agree. I have the luxury where we practice, everyone takes a biopsy. So thank you for all of you. Take a photo. So I'm spoiled.
Yeah, we have some, but certainly not all, probably less than half, 2 photos.
Yeah. It's helpful. I always encourage people to take photos. And I always encourage the dermatopathologists and pathologists to encourage to take the photos because we've made so many diagnoses because of the photos.
Right.
It's so helpful.
Thank you, Dr. Hopkins. So there is another question. How does the histopathologic severity of skin lesions correlate with systemic disease activity in conditions like dermatomyositis and systemic lupus?
Well, I know that if you have like massive mucin deposition and it clinically is, consistent with the papular and nodular mucinosis, that tends to be associated with more systemic lupus, like lupus with renal disease and arthritis and things like that. And you can get the same presentation in patients with dermatomyositis. I don't know if they're wondering about the amount of mucin correlating with disease. I don't know if that is something that's been specifically looked at. Maybe it has, but I'm not aware.
Do you
Yeah,
have anything to add, Dr. Casarino?
I don't think the severity of the skin inflammation necessarily correlates with, systemic disease activity. It's more the pattern, right? Like SLE is usually a much milder infiltrate. So it's a systemic form of lupus, but it's a much milder infiltrate than we usually see in DLE. So the dense, deep infiltrate is classic for DLE, whereas SLE is, I think of as very mild, usually superficial interface dermatitis.
Yeah, I agree.
So the severity can actually be paradoxical, compared to the clinical involvement.
Yeah, agree. And with DLE, because it's chronic, also called chronic cutaneous lupus, you'll get the basement membrane thickening,
right,
and plugging. And those patients who have DLE, only a smaller percent are going to have systemic disease. So
right,
I agree. There are some histologic changes.
Yeah, I think you can have more mucin in SLE, right? Supposedly, sometimes SLE and
I've seen
SLE
more,
can have more mucin, but less inflammation.
There is another question. So how can biopsies help in differentiating drug-induced connective tissue disorders from primary autoimmune conditions? So, and what histologic clues should one look for?
I think you're talking more of the vacuolar interface reactions would be my guess with the question. Because drugs don't usually cause mucin deposition. But they have looked at findings of drug-induced lupus versus idiopathic lupus, and there haven't been a lot of changes, like maybe more mucin, but like eosinophils, as I recall, weren't necessarily a defining factor because you can see it in both, although rare.
Right. Yeah, I remember a paper that specifically looked at the number of EOs and that surprisingly didn't differentiate, because you would think a priori that increased EOs would be associated with drug-induced lupus versus idiopathic lupus, but at least the one study I remember didn't find any significant differences. So
yeah, I think we read the same article.
Yeah.
That's the only thing I remembered from it.
Yeah.
No, thank you. Because we just talked about interface dermatitis, I saw one question somewhat related. So in cases of interface dermatitis, how useful is direct immunofluorescence or immunohistochemistry in distinguishing cutaneous lupus from other autoimmune blistering or inflammatory disorders?
Well, I know that I use CD123 a lot, just referring to the IHC question, part of the question. And I find that clusters of CD123 positive plasmacytoid dendritic cells at the interface of the epidermis and the hair follicles, like clusters of usually more than 10 or 20, and numerous clusters especially, definitely help support lupus. I am not familiar with that study specifically comparing it to drug-induced lupus, but I know it's very helpful in improving lupus or supporting lupus.
Yeah, I think they also asked about diff studies, right? Distinguishing lupus from other autoimmune blistering. do you use DIF much in that context? I actually don't like it that much, but I'd like to hear your opinion.
So we do DIF, direct immunofluorescence here, but we don't actually get a lot of biopsies for rule out lupus.
Okay.
But I do know that involvement of the hair follicle within the biopsies is very helpful. I am not personally, I don't have experience with rule out lupus, and it turns out to be drug and DIF experience in that specific situation.
Yeah.
But I do know from the literature that involvement of the hair follicles can be very helpful.
Right. But there are a lot of false positives and false negatives with the lupus span test results, so that's why I don't like it too much, because it can be negative in early lesions, like 2 or 3 months, less or less duration is often negative, and then it can be positive in sun damaged skins. You can have false positive lupus span test results. It can be positive in dermatomyositis in like 20% of cases. So a lupus span test result is not really sensitive or specific for lupus, in my opinion. And we do get a lot of biopsies for rule out lupus by DIF, and most of the time they're negative, but even when they're positive, I feel like it doesn't really give you a definitive diagnosis. So I think the H&E, the serologies, other things are more important.
And I think that's why people don't send us biopsies for that. I mean, we get them all the time for rule out pemphigoid and itchy people, but we almost never get those.
Yeah, but maybe it's different practices in California, but I unfortunately get a lot of diffs for lupus, and I don't think they're very useful.
Actually, there is a related question on this. What's the role of serum autoantibodies that you correlate while evaluating these disorders or cutaneous manifestation of systemic diseases?
I'm not exactly sure I know the question, but I know that you mean like checking serum for autoantibodies, right?
Yeah.
I mean, I personally put a lot of, or I suggest a lot of times to check for anti-Row and Law, SSA, SSB, because that can be positive sometimes when ANA is not so positive, and it can be helpful in sort of honing in on a diagnosis of subcutaneous SCLE or SCLE, subacute cutaneous lupus erythematosus. It can be helpful with hernia or chilblains associated with lupus. It'd be helpful for sort of an erythema multiforme-like reaction or the Rowell syndrome. So I personally will suggest that they check for Row law, and also they're drug induced. So if I get an older person with what I think might be a connective tissue like disorder that's new, a lot of times that's due to a medication. So, and that can also be Row law positive. So I don't know if that can differentiate it, but it can sort of say that it's drug induced and they can maybe alter the drug. So those are the ones, that's the one I suggest. I know that for dermatomyositis, there are a lot of different antibodies that are used, and not every single person with dermatomyositis will have these antibodies detectable. And so for those situations, I sometimes have them, be seen by either a derm room specialist or a room specialist to sort of hone in on which antibodies to get. Not all, because there's certain presentations that it might be more likely to be positive in with one antibody versus another.
You have any comments, Dr. Casarino?
No, because I'm not a clinician, so I don't order the serologies. I get more to the dermatologist and rheumatologist. I just recommend correlation with serology all the time. I figured they know the correct ones to order, right? Like Row and Law for dermatomyositis, ANA, double-stranded DNA for lupus, etc.
Yeah. I think that there are a lot of them now that have been more specific, like the especially with dermatomyositis that has more vasculitis, the dermatomyositis that has more interstitial lung disease. But I will just sometimes make a blanket statement. Sometimes I'll give a specific recommendation if I can see the clinical and I have made my own diagnosis, having looked at the clinical, but usually I just sort of have them correlate, like you say.
Right.
Thank you so much. I think these are all the questions that I found online, and thank you again, Dr. Junkins Hopkins, for your illuminating talk on this very interesting topic. And I
Thank you.
just want to thank all of our viewers for joining us from different parts of the world. And our next lecture is actually coming up. So it's on, I will tell you that this is March is actually Kidney Cancer Awareness Month. So in relation to that, we are organizing a talk on March 28th. So we will have Dr. Mehul Amin, who is a very noted genetic urinary pathologist. So he's going to talk about the different kidney cancer subtypes, and he's going to emphasize on how accurate diagnosis is important for guiding appropriate therapy, familial risk assessment for the patients, and optimal management. So hope you will be able to join us on March 28th, same time, that is 9 a.m. Pacific and 12 p.m. Eastern time, and hope to see you then. And thank you again, Dr. Junkins, Hopkins, and also Dr.
Thank you.
Casarino for helping us in organizing this series. Thank you so much.
Yeah, this is a great series. Thank you for including me. Have a
Thanks a
nice
lot.
day, everybody.
Thank you. Thanks, Jacqueline. Appreciate it.
Thanks. Bye.